Are you tired of making triple bogeys on your EKG reading or putting snowmans up on the card? Well, I'm here today with Dr. John Hicks, and he's going to take us through the basics and how to understand the EKG, because we all know you've got to go to the driving range before you can play the course. Dr. Hicks, take it away.
Well, I really appreciate that, Will. I've been playing golf for many years. Reading EKGs for many years. Back when I was a medical student in the early 80s, mid 80s, I learned that I could memorize everything. So our purpose today is try to teach you how to read EKGs without memorizing patterns. And in order to do that, we're going to have to back it up to the driving range, Will. I know some of you don't want to move backwards to go forwards, but that's necessary. All right, so we're going to start with the basics. Knowing that you understand some of the heart physiology and depolarization process, we're going to miss some of it or skip some of it. But I'm going to start at the very beginning so that you can get the most out of this EKG teaching. Can we splice? Okay, so what is an EKG machine and what does it do? Well, in a nutshell, the EKG machine was designed by a person years ago that was intended to record the electrical activity of the heart, because the heart is one of only two organs of the body that is electrically charged. And as it goes about its work, meaning contracting and delivering blood to the body, it leaves an electrical trail that can be inscribed on a piece of paper or on a computer. And by looking at that electrical trail, as physicians, we want to be able to understand what's going on with the heart. More importantly, we want to know what's wrong with the heart. But in order to find out what's wrong, we have to find out what's normal. So I'm basically going to introduce you into how an EKG machine works, why and how it was developed, and then we'll look at the normal depolarization sequence of the heart, and we'll go from there. And the time you invest now will save you hours down the road. So at the very beginning, we learn that a piece of heart muscle, and this is a representation, is electrically charged as it sits in the body. Now, this is just a piece of the heart muscle, all right? And it's charged negatively inside compared to outside, to a resting membrane potential of about minus 90 millivolts at rest, which you guys all know. So how did it get that way? Well, it got that way because of the sodium-potassium electrogenic pump, whereupon it's in the membrane here. It pumps out 3 sodiums in each cycle and pumps in 2 potassium for a net negative charge. And there are also anions sequestered within the myocardial cell, and it elevates the negative charge, but we use that to advantage. Along this myocyte, there are hundreds of thousands of sodium channels. So in a normal person, the sodium concentration in the serum is high or low. Well, you know it's high, because if you look at a BNP, you know that the sodium is about 140. So we'll assume the sodium concentration outside the cell, very high. What's the sodium concentration inside the cell? It's very low. So if we open up a sodium channel, we're going to have positive ions want to enter that cell. And that's basically how the heart depolarizes. So how does that relate to the EKG machine itself? So we have a piece of myocardium over here. And then we're going to have, in this particular case, a person with green eyes. We're going to put an eyeball over here and an eyeball over here, just for starters, okay? All right? And then we are going to hook this eyeball up to a machine, or basically what would be a transducer that can sense the depolarization from minus 90 millivolts during activation, okay, along an axis. It will sense that, and this transducer is hooked up to a stylus. And under that stylus is a piece of paper that's traveling in this direction at a set rate of 25 millimeters per second. Now, why am I telling you that? because you have to know it. All right, I won't tell you anything you don't have to know. So this stylus sits here. It's hooked up to the transducer, hooked up to an eyeball, which is an EKG lead, just one of the 12 on a 12-lead EKG system, sitting there scanning this piece of heart muscle, or the entire heart, and it's waiting for something to happen. It's waiting for a depolarization process. So whoever constructed the EKG machine put several eyeballs around the heart, scanning it to see when it depolarized. So if I were to prick right here a myocyte that is negatively charged to depolarize it in this particular myocyte, it would open the sodium channels and the depolarization process would propagate through the longitudinal axis towards this eyeball, key being towards. So this negative charge, when the sodium channels open up, would flip to a positive charge and it would depolarize along this axis, and this eyeball would see that electrical activity that occurs very quickly. So this eyeball being located over here will see a wave of depolarization moving towards it. That's critical. So the person that designed the EKG machine said, okay, if this eyeball sees a wave of depolarization moving towards it, it will inscribe on the paper a positive or upright deflection. Well, that's fine. That's by convention and design. So what about this eyeball? This eyeball is hooked up as well. And this eyeball, looking at the same piece of heart tissue, sees a wave of depolarization moving away from it. And it is designed to inscribe a negative deflection or a downgoing deflection. All right? So, if a wave of depolarization goes towards an eyeball or EKG lead, we get an upright deflection or a positive deflection. If the EKG lead sees a wave of depolarization going away, it's going to inscribe a negative deflection. Well, what if I were to put an eyeball up here? All right? Or down here. I'll put an eyeball here, all right, hook it up. What sort of QRS complex or wave would it draw? Well, by design, it will record a deflection that is equal up, equal down. And that is called an isoelectric deflection. Equal up, equal down, equal up, all the same. So from that, you can predict that if I were to put a lead here, all right, and hook it up, it would record a deflection that indeed is isoelectric, all right, because it's seeing a wave of depolarization that is perpendicular to the depolarization process, to its location or its eyeball. So it records an equal down, equal up deflection like this. It doesn't matter that it goes up and then down or down and then up. It's isoelectric, equal either way. So that's what an EKG machine is doing. So we're going to just take this two little steps further. So you have to ask yourself two questions. All right, that's fine. I understand that. But what determines the width of the QRS complex? And this is representative of a QRS complex. What determines how wide it is? Well, if the paper speed remains 25 millimeters per second, and people do change them, EKG techs accidentally change them, so you have to watch it and you have to know it. If the speed is constant, then what determines the width of this is how long does it take the electrical impulse from where it begins to where it ends. So for this eyeball, if it's narrow, it didn't take very long. So in a heart that uses the normal conduction tissue like the right bundle, the left bundle, etc., and the Purkinje fibers, then the QRS complex is going to be narrow. In a heart where the right bundle or left bundle might be damaged and non-functioning, the QRS by definition will be wide because there'll be cell-to-cell propagation of electrical activity, and that will delay the impulse from going from where it started to where it ended. The only other thing I have to tell you about this is the height, all right? What determines how tall this QRS complex is? Well, that is a function of really only one thing: the amount of myocardium depolarizing. You can imagine that a very skinny stretch of heart muscle will inscribe a very narrow QRS complex, while a very thick or tall piece of heart muscle will inscribe a tall complex because they're related. So the width is determined by the time it takes for the electrical impulse to travel through, and the height of the complex is determined by the size of the heart muscle depolarizing. So you can predict from that somebody with left ventricular hypertrophy will have very tall complexes or deep complexes. Somebody with a smaller heart that doesn't have LVH or RVH will have smaller complexes. You'll also know that if you see QRS complexes that are too wide, that somebody might have a conduction abnormality, but it gets more involved. But you have to understand that before we go any further. Okay. All right, so we know how the EKG machine works. Now we're going to relate it to an actual heart, not just a piece of heart muscle. And I don't want to offend anybody. We're going to start with the normal EKG, the P waves, QRS complex, T waves. I'll get back to that in a second. We have to have a good understanding of normal depolarization and the anatomy associated with that. So as you probably recall, the atria depolarize first, and that electrical stimulation comes from this little device here called the SA node. I know you know that. It is at the junction of the superior vena cava and the right atrium. It sends out an electrical impulse that travels down and depolarizes the right atrium in basically this direction. Bachmann's bundles carry it over and depolarize the left atrium in that direction. And then the electrical impulse after the atria contract hit the AV node, which is sort of here. All right, that's the AV node. And within the AV node, there is a physiological delay. You have to have a delay there within the AV node because you want there to be time for the atria to actually contract to fill the ventricles. If there's no time, it wouldn't do any good. So the electrical impulse hits the AV node, and in a normal person, those without WPW, all right, they have complete insulation of the right atrium and the left atrium from the right ventricle and left ventricle below through insulating material, and the only electrical bridge is the AV node. All right, so as you know, after the AV node, you get the bundle of His. We're not going to go into that. And then you get a left bundle, a right bundle. And that's all there is other than the Purkinje fibers. So depolarization, the Purkinje fibers kind of go out like this. So depolarization of the ventricles goes from endocardium to epicardium. You don't really have to know that so much for the EKG, but you have to know that for your test down the road. Now, the left bundle is actually two bundles in one. The right bundle is just one bundle, but the left bundle actually has two branches, and they're called fascicles. We call them the left anterior fascicle and the left posterior fascicle, but we just collectively call them the bundle right now. We'll talk about the fascicles later. So the electrical impulse hits the AV node. There's a physiological delay. Goes through the bundle of His, down the left bundle, right bundle, and the heart depolarizes in a specific sequence, which I need to outline. Because you're going to have to remember it down the road, but it's really simple. The septum goes first in this direction, okay, and then it goes, the RV goes here, 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 apex in this direction, and then epicardium to endocardium to epicardium here, here, here. That is the sequence, kind of like a reverse clock here. You got to know that. But if you add up all these electrical vectors, and Will's going to go over this in a minute, because these depolarize almost at the same time, it blends the QRS into one complex, and you really can't discriminate which is going first. So we're going to think of it as depolarizing at once on the lower end of the heart. So the actual electrical vector, which has magnitude and sense, is generally going to be depolarizing with an electrical axis this way. We're not going to teach you axis now, but you're going to have to know it. But this is going to help you understand. So That is the way the heart depolarizes. It's very important that you understand that and understand that the electrical vector of depolarization of the RV and the LV actually results in a vector that going somewhat this direction that will expand on. I want you to notice also that when the atria depolarize, the right atrium depolarizes down towards the bottom, and the left atrium depolarizes a little bit more over to the left lateral wall or left side of the heart. So looking at how this is reflected on the EKG, the P wave, of course, represents right atrial and left atrial depolarization. You knew that. But what you probably don't know is that the right atrium depolarizes slightly before the left atrium. That will become very important when you're learning about left atrial and right atrial enlargement. We'll get to that. And after doing the RAP model we're going to go over, or Will's going to go over, you will know that intuitively. You won't have to remember any of that. So you have a P wave, then you have a QRS. The QRS represents ventricular depolarization, combined right ventricle and left ventricle, and you know QRS. Of course, it may not be QRS, but you guys know that. We call it the QRS anyway, even if it just looks like an R wave or an RS wave. Then there's a time delay, and you get this next depolarization called the T wave. Well, it's not really a depolarization. It is the electrical reflection of repolarization of the left ventricle. All right, and then sometimes after a T wave, you get another little blip. It can be upright or invert. It's supposed to be upright, and that's called the U wave. Why is that important? Because prominent U waves are signs of hypokalemia. Inverted U waves are signs of early ischemia and other things, so you have to be aware of it. So then we have a delay, and then you have your next heartbeat. So this is one cardiac cycle right here. So I wrote in here too, we have a time from the beginning of the P wave to the beginning of the QRS is called the PR interval. Yeah, if anything is an interval, you have to measure. Why do you have to measure? Because an interval can be either too long or too short. Which reminds me of the surgeon I worked with when I was a medical student. I went in there and I was cutting sutures for him, cut them, and he said, that's too long. And then next day I went in there, or then I cut the next suture, he said, that's too short, all day long. It's either too long or too short. So the next day I went in to see him, said, hey doc, how you want me to cut the sutures today? Too long or too short? So if you have an interval, you have to measure it. A long PR interval will be associated with first degree AV block. A long QT interval from the beginning of the QRS to the end of the T wave can be a sign of a problem. A long one, caused by many drugs and electrolyte abnormalities, typically causes torsade de pointes, which you've probably heard of. So we're going to go over all of that later. So I just wanted to relate the normal depolarization sequence, the anatomy, to the actual EKG, relate it to a resultant vector as prep work for what Will's going to teach you next.
One of the most important things in golf is to execute the fundamentals. Like, how do I hit this 5-iron here? You always want to have a good 5-iron. Well, one of the most important things about EKGs is the fundamentals. And the most fundamental thing about reading EKGs is, well, what in the world am I looking at? I mean, lead 1, lead AVF, where in the world are those in relation to the heart? Well, here's an easy way to understand it with our world-famous bonehead EKG RAP model. Dr. Hicks came up with this when he was in medical school to help him remember exactly when he looks at lead 1, what part of the heart he's looking at. So, as we're drawing the rat model, one of the most important things is to remember is that rats have whiskers. So, this rat is going to have a whisker that goes out here, known as lead 1, at 0 degrees. The rat's going to have a whisker straight down towards his feet, called AVF, at 90 degrees. The rat is going to have another whisker called lead 2 at 60 degrees. Another whisker over here called lead 3 at 120 degrees. Now, wait a minute. Well, I thought rats had ears. They do. This rat's got 2 ears, a left ear called AVL at minus 30 degrees, and an AVF ear, sorry, not AVF, AVR ear, which we call no man's land. Now, these are 6 of the 12 leads, and I always thought it's very easy to remember by drawing the whiskers and putting on the ears. But there are importantly 6 other leads, and you might just have to memorize where to put these. So the first one being V1 is on this, looking over here at the right ventricle. It's out here, it's kind of away from everything. Then you have lead V2 right here and V3, which look at this the septum in between the RV and the LV. And then over here, we start with V4, V5, and V6. And so this is the rat model. And oh no, I hooked it in the woods. That's very complicated, and I think Dad, would you like to come teach us how to maybe get out of the woods here? We hook one.
Yeah, a lot of times you get in the woods, you want to go for the bomb and get it on the green in 2, and you just can't do it. You're going to risk triple bogey, losing it in the lake, hit another tree. So what we have here are a lot of leads, and well, you did a really good job of that. But what we didn't tell you is that of the leads, there were 2 sets of 6. So we have leads Will was talking about with the whiskers. They're called the limb leads. You got to know that. Now, the limb leads are the leads we use to calculate the axis, and that's all I was telling you about the vector moving to Will over there, the resultant vector. We're only talking about the limb leads, and the limb leads look at the heart in the frontal plane, frontal. Okay, all right, and that's very important. All right. So what are the V leads? Well, the V leads are called the chest leads. They look at the heart in an anterior, posterior direction or in a horizontal plane. Thought of another way, the V leads are looking at the rings of a tree. If we were to chop it down from front to back and lay it on its side, we're going to look at the rings, and the limb leads orthogonal to the V leads are looking at the bark of the tree. So the limb leads scan the front of the heart, and the V leads or chest leads, okay, look from anterior, posterior, front to back. And that's very important. We don't use the V leads. So we see a lot of the heart with the limb leads. So we see the inferior wall of the heart. As you can see, leads 2, 3, and AVF are near the rat's feet. So anything abnormal in the EKG in leads 2, 3, and AVF will reflect the problem at the bottom of the heart. Leads 1 and AVL are looking at the high lateral wall of the left ventricle. AVR doesn't really look at anything of any utility to anybody, so you just might as well forget it because everything's reversed. V1 looks at the right ventricle, somewhat lead V2, and somewhat the posterior wall. When you think of right ventricle, think of posterior, the backside of the heart. So leads V2 and V3, all right, look at the septum, but when we talk about the V leads, we add the prefix antero in front of it. So the V leads look at the anteroseptal regions, V1, V2, and V3. So then you can imagine that leads V4, 5, and 6 look at the lateral wall of the heart, but not like AVL and 1. They look at the anterolateral wall of the heart. So if we tell you ST segment elevation in a particular group of leads, like if we say ST segment elevation would indicate an acute myocardial infarction or heart attack, and the ST elevation on the 12 lead EKGs and leads V4, 5, and 6, then you automatically know it's an acute anterolateral myocardial infarction. If you see ST elevation in leads AVL in one, then you know it's a high lateral or a lateral wall myocardial infarction. And y'all tell us, if you see ST elevations in lead 2, 3, and AVF, you're probably looking at a bonehead inferior wall myocardial infarction. We're going to apply that to everything as it pertains to the leads. So the utility of the RAT is to locate the leads around the heart without memorizing, 2, 3, and AVF, look at the inferior wall of the heart. Well, if you see this RAT in your mind, you know that. You don't have to ever remember that. And we added in the V leads because that's half the EKG, right? Well,
Absolutely.
so knowing that and adding the prefix antero, it has an enormous utility, but we're going to have to just keep moving from here, and we'll talk about those things later.
Oh, another downhill slider. Whew. Close putt. Well, again, we're back here with Bonehead EKG, and we're going over some fundamentals which are very important for your understanding. Remember, we don't like memorizing over here at Bonehead EKGs. So, Will, this whole axis thing, I really don't know how to calculate it, and it seems kind of complicated. Why don't you take us through it? Well, axis is a lot easier than people realize, but the key being you gotta see the rat. So you practice drawing your rat, and then when it becomes in your head second nature, calculating this axis is going to be really easy. You're going to start making those downhill sliders. So normally when we get an EKG, it looks something like this. We got these leads over here. We got 1, 2, 3. Big question I get is, what's the first thing I should do? What is the very first thing I should do? Well, the very first thing you should always do is look at the bottom rhythm strip, but we're not there yet. We're not there yet. Okay? But calculating the axis is very important, and that's actually the next thing you do. So after you look at this rhythm strip, you're going to come up here to lead 1. This is always the first lead you look at to calculate the axis, because we got to figure out what quadrant or where in the world this arrow thing is going. So lead 1 we see is isoelectric. All right, we go, okay, lead 1's isoelectric. We know that means the eyeball is looking perpendicular. It's seeing it from a perpendicular angle. So we come over and we end up in AVF, which is always the second lead you look at to calculate the axis. So we come over here to AVF, and we see the AVF is upright. So we know by default that it has to be going towards AVF. So this little tail, which I think is best described by my tie, we know my tie is going towards my belly button, towards AVF, going towards the feet, okay, because it's straight up. We know that it's perpendicular to 1, so this axis, because this is isoelectric and this is straight up, our axis is going to be 90 degrees because the entire majority of the vector is pointing straight down towards AVF. Now, a normal axis is from 90, okay, also known as your belly button, to about minus 30, which is also known as the left ear. So think, when you're wearing a tie or you borrow somebody's tie, you've got from 90 to negative 30 is normal. So always make sure next time you're wearing a tie or playing with a tie, you just want to make sure that you're practicing your axis. It really helps more than I think people realize. So, okay. All right, we can. Are you ready to stop laying up on reading EKGs? It's time to stop laying up, and it's time to start going for some pens. The most applicable way I see the RAT is when you're diagnosing heart attacks or diagnosing cardiac ischemia. And one of the big things here is you can tell where the heart attack is by looking at this RAT. It is so useful to look at the RAT and understand where the underlying pathology is with the heart attack. So we start here. We've got classic ST elevation here, and just trust me, this is leads 2, AVF, and 3. Okay, so that's telling us right now when we look at ST elevation in 2, 3, and AVF, we know that it's attacking this inferior wall. So what's really applicable is when you have your anatomy, and I really suggest drawing out the coronary arteries and the anatomy of the heart and having it next to your rat, because that's really when you're going to start making connections or start hitting some big-time golf shots and start making some eagles. So when we have here the right coronary artery, all right, we know that it's going down towards 3 AVF and 2. So we know that likely that this right coronary is blocked with an inferior wall infarct. Now, let's look at another heart attack. So we're going to come up here and just trust me that we've got ST elevation here and V2 and V3. All right, so when we come over here, we got V2 right here, we got V3 right here. We know this is an acute aneuryseptal aneuryseptal infarct. So we come over here, we look at our anatomy. This is why it's so important to have your anatomy near your rat. You got the LAD going here, V2 and V3 here. We know that this aneuryseptal infarct is likely going to be due to a blockage of our LAD coming down here. And now you see when we apply the anatomy to the rat, we're understanding. We don't have to memorize where the heart attacks can be, because we know, we see it, and we see it. Now, Dad, you're going to come show us about the world famous posterior wall infarct, which is pretty scary.
Well, what you did was, kind of like hitting an 8-iron, 170 yards in a par 3 and getting in with about 10 feet, probably 2 or 3 putt, depending on your day. What I'm getting ready to show you, diagnosing posterior infarcts, a little bit hard. It's like hitting a driver off the deck. You get about 280, trying to get on the green in 2 on a par 5, you're down. You got a lot of money on the bet. So we're going to talk about posterior infarcts. So as Will was saying, the utility of the rat is if you know that ST elevation is a sign in certain circumstances, particularly if it's convex, okay, then it's an indication of an acute myocardial infarction, and Will was relating to arteries, and we'll go over that in more detail later. But in the first EKG he showed you, he saw acute ST segment elevations in 2, 3, and AVF, so you know that that's an inferior infarct. If you look at the rat, well, you can memorize 2, 3, and AVF, and that's indicative. ST elevation is indicative of inferior infarct, or you could just be able to see it. In the rat model, V2 and V3 look at the aneuryseptal region, or the septum. We always add the prefix antero when we're talking about the V leads or the chest leads. So when he showed you the EKG with the coved upward convex ST elevation in leads V2 and V3, you knew the patient was having aneuryseptal infarct. If he had an EKG that showed acute ST segment elevation in V4, 5, and V6, you know the patient's having an anterolateral infarct. You don't have to memorize it. If the patient had ST elevation in leads 1 and AVL, it's an acute lateral wall infarct. It's quite dramatic. You can have reciprocal changes in AVR, but forget that. But the posterior wall is the great event. And in our, I actually wrote a book called Bonehead Electrocardiography. And in that's the way we titled it. But if you can diagnose an acute posterior infarct, you're something. And that's not easy unless you understand it. So I have an EKG here. Everything's reversed in the posterior wall, and you got to look in leads V1 and V2 for the posterior wall. You remember V1 is looking over the right side of the heart, right ventricle, but it's also creeping around the corner and looking at at the posterior wall. But it brings its friend V2 with it. So what we have in this particular patient is who's having a heart attack. Well, in this patient's having an acute inferior infarct. You have massive ST segment elevation and leads 2, 3, and AVF. That's unequivocal. And then you start scanning, you think your job's done. It's not. You have to look at the last half of the EKG. You want to look at the whole EKG. You don't want to get tunnel vision. And you look over here and you say, well, my goodness, we have some massive ST depression in lead V2 and even V3. What's going on? Well, that, my friends, is evidence of an acute posterior infarct. Now, the easy way to do that, you can memorize that. Everything's reversed in the posterior wall. So if we take this EKG and we put our finger on lead V2 and we flip it upside down and backwards, and we look at it from the back side, you can see ST elevation and Q waves in V2 by flipping it upside down and backwards. So you take the EKG for posterior infarcts, you see the ST depression, just put your finger on it to mark it. Flip it upside down and backwards, and then you look through a light. And I don't really have much of a light here. We can here, but you can barely make out where my finger is. ST elevation and a Q wave in V2, and that is the hallmark of a posterior myocardial infarction acute. So, Will and I have used this as an introduction to the utility of the rat. We haven't even talked about left atrial enlargement, right atrial enlargement, chronic heart attacks or old heart attacks marked by Q waves, and we're going to do that later. But I think that's enough for today. But understand that if you can draw this rat and understand this, you will know where the heart attacks are. If you overlay the coronary arteries, you know what arteries involved, and it's not very complicated. It's very, very easy. You'll never have to memorize that. You'll know if a patient has RVH. You'll know if they have LVH. You'll know if they have strain. You're going to be able to look at the polarity of the T waves using Will's tie in the next segment. And you won't have to memorize much at all. So thank you. And Will, that was a good round today. Do you think you played okay?
I think I broke 72.
What'd you shoot on the back nine?
Oh, God, 4 or 5 under.
No, I mean the back nine after the front nine, 72.
And that's all, ladies and gentlemen, for today. Bonehead EKG.
Well, you had good aim on that shot. Your direction was good, but I think you caught a little thin and it went over the green. So what we're going to have to do is chip back on the green, make it a little simpler. All right, we're just going to have to do that. So when you're talking about the axis, Will's absolutely correct in teaching it that way. Unfortunately, unless you're a scratch golfer, it's going to be difficult. So we're going to make it easy. So when I'm calculating the axis, and you have to, all right, always look in lead 1 first and ask myself one question. Is the QRS upright or inverted? Okay. If in lead 1, the limb leads, that's because that's the only leads we're talking about, we're looking at when we're talking about axis. If the QRS is upright in lead 1, based on what we taught earlier, that means the wave of depolarization is going towards 1. That means it could be anywhere in this half of the paper based on this model right here, this rat model. So we know the axis is going to be on this side of the paper. So then I go into a lead that is 90 degrees perpendicular to lead 1, and I think, okay, AVF. I do it every time this way. So I ask myself the same question. Is the QRS complex mostly upright or inverted? For if in this particular case it is upright, then I know for a fact that the mean vector of the axis is going towards AVF, not away. So if it's going in this half of the paper and it's going down towards AVF, we've narrowed it down to this quadrant right here. Okay, this is your layup zone. This is your lag zone. So now we're going to have to narrow it down. So the third step in this process is you have to look in the limb leads for the isoelectric lead. That is, where is the QRS equal up, equal down? And to do that, we just have to look at the EKG in the limb lead. So I'm going to show you this one EKG here as an example. So if I were going to calculate this axis, so you just have to trust me that this is leads 1, 2, 3, AVR, AVL, AVF. Those are the only leads we're going to be looking at right here, and you don't need to be able to read the EKG. Just tell me the big spikes are the QRS. So if I follow this model, and I'll erase this, all right, in this particular EKG, if we want to calculate this axis, we look in lead 1. Is the QRS upright or inverted? And in this particular example, it's clearly upright. So we're going to give it an upright, all right? And then I always go to AVF, and AVF is right down here. Is it upright or inverted? It's upright. So that means the axis is going towards AVF. Well, lead 1 says it's going in this quadrant. Being positive in AVF means it's coming towards it. So we've narrowed it down to this segment, this 90 degrees here with our lag. And then we're going to look for the isoelectric lead. And in this particular case, the lead that looks most equal up and equal down is lead AVL. So we're thinking, okay, so what is 90 degrees perpendicular, because it is the isoelectric lead, what is 90 degrees perpendicular to AVL? Lead 2. And lead 2 is plus 60 degrees. So we can predict, we know that the electrical axis is 90 degrees perpendicular to AVL, and that it's going straight towards lead 2. And without looking at this EKG, I can guarantee you the QRS complex is going to be largest in lead 2 because it's going straight at it. It's not going off angle. My finger's on lead 2. It's the tallest complex. So that is an example of how to calculate that. You say, well, that's not too easy, not too hard. So let's just grab another one. Grab another EKG. Here's another patient. All right, we're going back to our process. We're going to line up the putt, which means we're going to go to lead 1. Is it upright or inverted? In this particular example, it's upright. So it is going indeed towards lead 1. So it's upright. All right, I go to AVF. Whoa, buddy. It's not going towards AVF. It's mostly negative. This has got a break to it. You're going to have to give 6 inches of a break on this particular putt. It's going away from AVF, so it's down. So it's upright lead 1, going on this half. But in this particular case, because it's negative in AVF, it's going away from AVF. So what is towards lead 1, but away from AVF? You're in this quadrant right here. So then we find the isoelectric lead, and it is, we can't find it. But it's very close to isoelectric in lead 2, but a little more negative, so it's a little north of lead 2. What is 90 degrees perpendicular north of lead 2? Well, 90 degrees perpendicular to lead 2 is AVL, but it's a little north of that. And Will said a normal axis is minus 30 to plus 90. This is just north of minus 30. This is classic left axis deviation, and this is an example of a left anterior fascicular block. And to prove it to yourself, you look in AVL, and you see a tiny Q wave in AVL. Left axis deviation, tiny Q wave, AVL, left anterior fascicular block. Well, we got out of the woods, we lined up the putt, we made the putt. Now we'll go on to the next session.